Hello everyone, I am Dr. Ankita Singh, Reader, Department of Oral Pathology and Microbiology, Babu Banarsidass College of Dental Sciences, Lucknow. Today's lecture is on benign epithelial tumors. So we have squamous papilloma. It seemed to be associated with papilloma virus, positive in skin warts. So mostly there is HPV type 6 and 11. Fourth most common oral mucosal mass, and it is found in 4 of every 1,000 individuals. So this is the picture of squamous papilloma. You can see on buccal mucosa finger-like projections, cauliflower-like, and also on the tongue. It is an exophytic growth. There are numerous small finger-like projections seen. The lesion is roughened, verrucous, cauliflower-like surface, nearly always well circumscribed pedunculated tumor, and occasionally sessile. It is painless, usually white, sometimes pink in color. So site are tongue, lips, buccal mucosa, gingiva, palate, particularly adjacent to uvula. It is few and it rapidly enlarges to more than 5 then sometimes several centimeters also. It occurs at any age, mostly young children. The common wart or verruca vulgaris is frequent tumor of skin and it is analogous to oral papilloma. Uncommon in OMM but extremely common in skin, and it is associated virus are HPV2, 4, and 40. So there is a narrow stalk which appears wide due to considerable surface keratin and presents as multiple or clustered individual lesions. It is contagious, capable to spread to other parts of an affected person's skin or membrane by auto-inoculation. The oral lesions appear to arise through auto-inoculation by finger sucking or fingernail biting. So this is the histopathologic feature. You can see the connective tissue and these are the finger-like projections. So consist of long, thin finger-like projections extending above the surface of the mucosa. There is a continuous layer of stratified squamous epithelium. There is thin central connective tissue core and it supports the nutrient blood vessels. Some are, you can also see hyperkeratosis. So essential feature is proliferation of spinous cells in papillary pattern. Occasionally, bacillar hyperplasia is seen and mild mitotic activity. So one important thing is coelocytes. What are coelocytes? These are HPV altered epithelial cells with perinuclear clear space and nuclear pycnosis. So they may or may not be found in superficial layers of the epithelium. Then there are also chronic inflammatory cells which may be present. Now, keratoacanthoma. It is very important to know that it is a self-healing carcinoma. So low-grade malignancy that originates in pilosebaceous glands and considered to be a variant of invasive squamous cell carcinoma. The cause is unknown. Epidemiologic data supports sunlight as an important etiologic factor. Chemical carcinogen may be one of the etiologic factor. So trauma or HPV genetic factors or immunocompromised status. Recent studies have shown chromosomal aberrations also. It occurs in all age group. It increases with age, twice as frequently in men as in women. Less common in dark-skinned individuals and mostly seen in sun-exposed areas. So we can see it on face, neck, dorsum of upper extremities that are the common sites. 8.1% cases on lips and vermilion border of lip are affected. We can see intraoral lesions, which is uncommon. So lesions are solitary, begin as firm, round, skin-colored or reddish that rapidly progress to dome-shaped nodules with a smooth, shiny surface and central crateriform ulceration and keratin plug that may project like a horn. So this last line is very important. 1 to 1.5 centimeter in diameter. It is often painful and regional lymphadenopathy may be present. So as I've said, it begins as small firm nodule, develop to a full size in 4 to 8 weeks, then persist as static lesion for another 4 to 8 weeks, then undergoes spontaneous regression over next 6 to 8 weeks period by expulsion of the keratin core with resorption of the mass. So lesion over 2 years duration reported and recurrence is rare. So this is the histopathologic picture. So it consists of hyperplastic squamous epithelium growing into underlying connective tissue. And the surface is thickened layer of parakeratin or orthokeratin with central plugging. Epithelial cells, there are no atypia, but occasionally dysplastic features found, and islands of the tumor often appear to be invading. They may invade perineural space. The connective tissue shows chronic inflammatory cell infiltration, and there is a characteristic feature at the margin where the normal adjacent epithelium is elevated towards the central portion of the crater. Then an abrupt change in normal epithelium is there as the hyperplastic acanthotic epithelium is reached. So oral nevus, it is characterized as hematoma, developmental malformation. The nevi are benign proliferation of nevus cells in either epithelium or connective tissue. In 1943, Ackerman and Field have reported the first case of oral nevus, and King et al. Used less specific term intramucosal nevus. It is common in adult whites, and intraoral lesions are much less common. So nevi may be classified as congenital or acquired according to Bonner and Hansen. On basis of histologic location of the nevus cells, cutaneous acquired nevi can be classified into three categories: junctional nevi, compound nevi, and intradermal nevi. So junctional nevi when nevus cells are limited to basal layer of the epithelium. Compound nevus when nevus cells are in epidermis and dermis. And intradermal nevus, nest of nevus cells are entirely in the dermis. So oral nevi, intradermal is replaced by intramucosal term. So junctional nevi, it is noted in infants, children, young adults. As nevi penetrate into dermis, their pigmentation diminishes. Approximately 15% intramucosal nevi are non-pigmented. So most common mucosal type is intramucosal nevus. Junctional and compound nevi are 3 to 6% of all oral nevi. So clinical features. Ainsworth and his colleague separate congenital nevi of skin into small and garment nevi. So small nevi is more than 1 centimeter in diameter and usually 3 to 5 centimeter. Garment nevi is more than 10 centimeter in diameter, seen in skin. Congenital nevi, 1 to 25% of neonates with time change from flat, pale, tan macules to elevated verrucous hairy lesions. And intraorally, it occurs rarely. So acquired nevi, it is extremely common, present in 8th month of life and increase with age. Peak is seen in 3rd decade of life. Histologic variants of acquired are neural, balloon cell, and halonevi. And only halonevi is clinico-pathologically distinctive. The neural and balloon cell nevi are histologic variants of intradermal and compound nevi. So intradermal nevus, also called common mole, it is most common lesion of skin, several scattered over the body, and smooth flat lesion or may be elevated above the surface, may or may not exhibit brown pigmentation, often shown strands of hair growing from its surface, and seldom occurs on soles of feet, palms of hands, and genitalia. Then intramucosal nevi, 25% hard palate, 17% gingiva, 12% vermilion border of lip, and 9% labial mucosa. Now, you should know about junctional nevi, compound nevi. So, junctional nevi may appear clinically similar to intradermal nevus, distinction being chiefly histologic. Compound nevi is composed of two elements, intradermal nevus and overlying junctional nevus. Spindle cell or epithelioid cell nevus, also called Spitz nevus, occur chiefly in children. Only about 15% appearing in adults, may appear histologically similar to malignant melanoma in child. Then there are blue nevus. It is second most common type in oral cavity, common in mouth than skin. So blue nevus is 2/3 on hard palate, and it is a true mesodermal structure which is composed of dermal melanocyte, rarely undergo malignant transformation. It chiefly occurs on buttocks, on dorsum of feet and hands, on face, and occasionally on other areas. At birth, they may appear in early childhood and persist unchanged throughout life. So the lesion is smooth. It exhibits hairs growing from the surface and varies in color from brown to blue or bluish black. 85% of oral nevi are found in patients younger than 40 years. So mostly seen in whites, about approximately 55%. Oral mucosa nevi mostly seen in females. The most common in hard palate, 40%. Second most common site is buccal mucosa. Other locations are vermilion border of lip, labial mucosa, and 10% occurs in gingiva. Only one mucosal nevus have been reported on tongue or floor of mouth. Oral manifestation, asymptomatic, seen in routine examination. Pigmentation usually varies from brown to black or blue. Present as well circumscribed, round or oval, and are raised or slightly raised in 65 to 80% cases. 15% amelanocytic sessile growth. And differential diagnosis can be melanotic macules, amalgam, tattoo, etc. So histopathologic features, the nevus cells are assumed to be derived from neural crest and relationship with true melanocytes remains uncertain. So nevus cells are ovoid, round, spindle-shaped cells with pale cytoplasm may contain granules of melanin pigment in their cytoplasm. The nucleus is vesicular, lack dendritic process typical of melanocytes. In addition, they either lack contact inhibition or lose it shortly after proliferation process begins. So grouped in sheets or cords called nest or theque. Nest cells also have the ability to migrate from the basal cell layer into the underlying connective tissue. And there are multinucleated giant cells, sometimes they are present, and mitotic figures not common. Junctional nevus, zone of demarcation is absent and nevus cells contact and seem to blend into the surface epithelium. This overlying epithelium is usually thin and irregular. Shows cells apparently crossing the junction and growing down into the connective tissue, the so-called abdrop-pung effect or dropping off effect. This is very important. So this is the picture. So compound nevus shows features of both junctional and intradermal nevus. There are nest of nevus cells are dropping off from the epidermis, while large nests of nevus cells are also present in the dermis. Intradermal nevus cells are situated within the connective tissue and are separated from the overlying epithelium by a well-defined band of connective tissue. You can see it over here. So thus, in the intradermal nevus, the nevus cells are in contact with the surface epithelium. Spindle cell or epithelioid cell nevus, commonly composed of pleomorphic cells of three types. Spindle cells, oval or epithelioid cells, both mononuclear and multinucleated giant cells. They are arranged in well-circumscribed sheets, and there is generally considerable junctional activity. So blue nevus, common blue nevus, and cellular blue nevus. Common blue nevus, elongated melanocytes with long branching dendritic process lie in bundles, usually oriented parallel to epidermis in the middle and lower third of dermis. There is no junctional activity. So melanocytes are packed with melanin granules, sometimes obscuring the nucleus, and these granules may extend into the dendritic processes. Cellular blue nevus. These are large, round spindle cell with pale vacuolated cytoplasm. These cells are arranged in alveolar pattern. So this is all for your lecture. Thank you.